Have you ever stopped to think about, that simple pill you take, how it can have these um, really profound effects, sometimes even unexpected ones right across your body?
Hmm.
Or like why a medication works fantastic for one person but maybe does nothing for someone else, even if they seem similar.
Yeah, that individual variability is huge.
It really is. There's this whole hidden world of science happening with every single dose, every reaction. So welcome to the deep dive.
Glad to be diving in.
We're all about taking complex info and, well, turning it into those aha moments. And today we are really getting into the weeds of pharmacology, that intricate dance between drugs in your body.
Yeah, the how and the why.
Exactly. And our guide for this, it's an incredibly detailed source, Illustrated Pharmacology for Nurses, really comprehensive, traces drugs right from their origins to, their effects inside us.
And our mission here basically is to pull out the key insights from all that material. We want you to understand not just what drugs do, but why they do it.
Yep.
We'll look at how your body handles these things, these powerful substances, and also, importantly, the ethical thinking behind how they're developed and used.
Should be some surprising stuff in there.
Oh, definitely. Get ready for some real eye-openers about medicine.
Okay, so let's start right at the beginning then. Where do these drugs even come from? It's quite a story, historically speaking.
It really is. For, millennia, remedies were mostly natural, right? Think like ancient herbs, minerals, animal-derived stuff.
The original pharmacy.
Pretty much. But here's what's interesting. Today, most drugs are made through, complex chemistry or biotech. But those natural products, they haven't gone away. Actually, they're still a really key source for finding new drugs. It's kind of amazing.
So nature's still teaching us things.
Absolutely. It shows that even with all our fancy science, we're still learning from, the original chemist nature itself.
Okay, so once we find these potential substances, natural or synthetic, there's this whole process before they get anywhere near a patient, right? You mentioned ethics and safety.
Oh, absolutely. Before anything reaches you, it goes through an incredibly rigorous process. And the guiding principles there, they're really foundational.
Like what?
Well, in early research, the animal studies, there's a big ethical push for the 3 R's.
The 3 R's.
Yeah. Refine methods to minimize any suffering, reduce the number of animals needed, and crucially, replace animal use whenever possible.
Okay.
So, for instance, we're seeing more and more use of computer models to simulate how a drug might react. Helps make decisions earlier on.
That sounds like a really positive step, using simulations, reducing animal testing. But then when you move to human research, that must be where the ethical considerations get even more intense.
You're absolutely right. That's paramount. Human research has to be completely ethical, completely legal. It always needs approval from independent ethics committees. And a really key document here globally is the Declaration of Helsinki. Started back in '52, but it gets updated.
And what's the core message there?
The absolute core is patient or volunteer well-being, the risks and benefits to them always overrides the scientific goals. Always.
That seems right.
And participants, they should go in expecting at least the possibility of some clinical benefit. And of course, it has to be voluntary. Informed consent is huge.
So not just signing a form.
No. It means getting detailed info, talking it through, getting it in writing, making sure you understand the risks, the procedures, everything. And then you sign, confirming you get it.
You can back out.
Anytime. For any reason. And it can't affect your current or future medical care. That's non-negotiable.
Okay, so a drug makes it through all that. Development, ethical reviews. How does it then get categorized for, everyday use? We hear things like controlled substance or prescription only. What do those actually mean for us?
Yeah, it's all about oversight, really. Making sure powerful medicines are handled correctly. Different countries have different systems, but the idea is to classify drugs based on, their potential for harm or misuse or dependence.
Right.
And that dictates who can legally supply them under what conditions. So things that are really potent or have a high risk of abuse, they'll usually be prescription only.
Meaning you need a doctor's script.
Exactly. From a registered practitioner, dispensed by a proper pharmacy. Other stuff, lower risk, might be available over the counter. The whole system is designed for safety and control. These things help, but they are powerful.
Okay, so that's the journey from discovery to the pharmacy shelf, basically. But that's just the outside story. The real magic, or maybe the real science, happens when these molecules actually get inside your body. How does that pill you swallow actually start doing anything? This gets us into pharmacodynamics, is that right?
That's it, exactly. Pharmacodynamics. It's basically what the drug does to your body. And a lot of drugs work as, well, they're called agonists. Yeah. Think of it like this. Your cells have specific locks on them. We call them target proteins. An agonist is like the key that fits that lock.
Ah, the key and lock analogy.
Right. And when it fits and turns, it switches something on inside the cell, causing a response. Like a morphine, it's an agonist for opioid receptors. It turns on your body's pain relief system.
Okay, that makes sense. Key fits the lock, turns it on. But here's the thing that gets really interesting and sometimes frustrating, right? Why do two people, maybe even the same size, take the exact same drug, same dose, but get totally different effects?
Yes. The million-dollar question.
One person feels great, the other gets side effects, or maybe feels nothing at all.
That's the core of individual variability, and it's a massive challenge in medicine. The truth is, how someone responds often lines up better with the drug's concentration in their blood rather than just the dose they took.
Ah, okay, so it's not just the dose, it's how much actually gets into your system and stays there.
Precisely. Because how your body handles the drug, absorbs it, distributes it, breaks it down, gets rid of it, that whole process, which we call pharmacokinetics, varies hugely from person to person.
Right, pharmacokinetics.
Yeah.
What the body does to the drug.
Exactly. And this leads to some really important definitions. We talk about the effective dose 50 or ED50.
ED50.
Yeah, the dose that gives the desired effect in like half the people who take it.
Okay.
Then there's the toxic dose 50, TD50. That's the dose causing an adverse effect in half the users.
Like the bad stuff.
Mm-hmm. And then theoretically, the lethal dose 50, LD50, the dose that would be lethal for half the users.
Wow.
And what's really crucial here is that gap between help and harm. It's not fixed. It's different for everyone. It's like walking a tightrope. And the rope's position changes depending on your genetics, your health, other meds.
So it's not just different strokes for different folks. It's biologically fundamental.
Absolutely. It's the central challenge. Finding that sweet spot, ideally for you specifically, that's where personalized medicine comes in.
Okay, so if pharmacokinetics is the drug acting on the body, pharmacokinetics is the body acting on the drug, the journey it takes.
Mm-hmm.
How does our body actually process these things?
Right. Pharmacokinetics, it covers 4 main stages: absorption, getting into the system; distribution, spreading around; redistribution, maybe moving between tissues; and elimination, getting rid of it.
Absorption, distribution, redistribution, elimination. Okay.
And yeah, while we talk about them as stages, you got to remember they're all happening at the same time, just at different speeds, from the moment it enters until it's gone.
Right. It's not sequential, like steps 1, 2, 3, 4.
No, much more dynamic. So think about how you take a drug, the route. Most common is enteral, like by mouth or rectally. Oral drugs, pills, they're mostly absorbed in the small intestine. But then many drugs, especially ones that dissolve in fat, go through this thing called first-pass metabolism.
First pass. I think I've heard of that. In the liver.
Exactly. The liver gets a first shot at breaking it down before it even reaches your main bloodstream, which means less active drug gets through. That's often why you need a higher dose orally compared to, say, an injection to get the same effect.
Makes sense. So what about injections, the parenteral routes?
Right. So you can inject directly into an artery that gives a very high concentration right where you need it, like chemo for a specific tumor.
Okay.
Or into a muscle intramuscular. Or IM, muscles have a good blood supply, so it gets absorbed pretty quickly.
But not for everything.
No, you wouldn't use IM for drugs that really irritate tissue, like diazepam.
Yeah.
And if someone's in shock, their muscle blood flow is poor, so IM absorption is unreliable. Then you'd need intravenous, IV, straight into the vein. Gets it working immediately.
Got it. Okay. Moving beyond pills and injections, you also see drugs as like creams and ointments for the skin. What's the deal there? Why choose one over the other?
Oh, topicals.
Yeah.
Yeah, it mostly depends on the stuff the drug is mixed into and what kind of skin issue you have.
Okay.
So ointments are usually water in oil, more oily.
Greasier?
Yeah, can feel greasy. But that makes them great for really dry, scaly skin because they form a barrier, lock in moisture. People often use them at night because they're a bit messy.
Right.
Creams, though, are oil and water. Lighter, they absorb easier, better for skin that's moist or weeping, or just for daytime use because they feel nicer, more cosmetically acceptable.
Okay, so ointment for dry, maybe overnight, cream for less dry, or daytime. That makes sense. Now, thinking about all these processes, putting multiple drugs into this system, interactions must be a huge thing to watch out for.
Oh, absolutely. Huge. Your body's like this incredibly busy chemical factory, right?
Yeah.
Introduce multiple chemicals and, yeah, things can interact in unexpected ways. Just simple stuff first, like mixing drugs for IVs. Generally, avoid adding drugs to buffering fluids unless you're told to. Things like saline or glucose are usually safer. And always label things. Check the expiry dates. Basic but vital.
Right, the practicalities.
Yeah.
But inside the body, how do they interact there?
Okay, so there are two main types of interactions. First is pharmacodynamic. That's when one drug affects how another drug works, but without actually changing how much of that second drug is in your system.
So they're interfering with each other's actions, not their levels.
Exactly, like two keys interfering at the same lock, maybe. The second type, often more significant clinically, is pharmacokinetic interaction. That's where one drug actually changes the concentration of another drug in your body.
Ah, okay. And how does that happen? How does one drug change another's concentration?
The biggest culprits, the most important causes of serious pharmacokinetic interactions involve enzymes specifically, enzyme induction and inhibition.
Induction and inhibition.
So enzyme induction means one drug speeds up the body's enzymes that break down another drug.
So it clears the second drug out faster.
Right. Which reduces its effect. If you start a new drug and notice your old one isn't working as well after a week or two, induction could be why.
Any examples?
Classic one is carbamazepine, used for epilepsy. It can speed up the metabolism of warfarin, the blood thinner. So the warfarin becomes less effective, risk of clots goes up.
Wow, okay. And inhibition?
That's the opposite. One drug slows down the enzymes metabolizing another drug, so the second drug builds up.
To potentially toxic levels.
Exactly. That can be really dangerous.
Okay, that's critical to understand. Now, here's something that sounds a bit weird. Sometimes your body seems to adapt or almost fight back against a drug.
Yeah.
Especially if you stop it suddenly.
Yeah. That's a great way to think about it. We call it physiological tolerance, and sometimes it leads to a rebound effect. It's super important.
Okay, explain that.
Take beta blockers, right, for high blood pressure. They work by blocking certain receptors for noradrenaline, mainly in the heart. But your body, clever as it is, notices this blocking and responds by, well, making more of those receptors. It's called upregulation.
So it's trying to compensate.
Exactly. Now imagine you suddenly stop taking the beta blocker. All that noradrenaline suddenly has loads more receptors to latch onto.
Uh-oh.
Oh, is right. You can get rebound hypertension. Blood pressure shoots up, sometimes even higher than before you started the drug.
Wow. That's a powerful reminder not to just stop certain meds cold turkey.
Absolutely. It shows how dynamic the body's response is. You always need to follow advice on how to stop medications, especially ones like that.
Yeah. Okay, that point about individual variability, the rebound effect.
Yeah.
It all highlights how complex this is. But let's talk about something maybe more straightforward but still serious. Drug errors.
Yeah, unfortunately, they happen, and they're a major concern.
Where do they happen?
Anywhere, really. From the moment it's prescribed to how it's dispensed to when it's actually given or taken.
And the consequences.
Can range from, putting someone at risk, maybe delaying recovery, to being truly catastrophic, even fatal.
And it's not just doctors or nurses.
No, errors can originate with healthcare professionals, but also with patients themselves, misunderstanding instructions, maybe. It just underscores the need for everyone to be really vigilant, especially with powerful drugs or when giving meds to vulnerable people, little kids, the elderly, unconscious patients. The margin for error is just so small there.
Okay, speaking of vulnerable groups, how does age specifically impact how drugs affect us? You mentioned the elderly, children.
Yeah, age is a huge factor. Older patients, for example, are generally more sensitive to adverse effects. Think sedatives, strong painkillers.
Why is that?
Well, partly because their body's ability to compensate for physiological changes is often reduced. And really importantly, organ function, especially liver and kidneys, which are key for clearing drugs out, tends to decline naturally with age.
So the drug hangs around longer.
Exactly. Its half-life increases.
Oh.
So standard doses can build up. That's why the rule is often start low, go slow with older adults. Monitor really carefully.
And kids.
They're not just small adults. Their bodies are different, still developing. Especially very young children, they have a different water-to-fat ratio in their bodies, more water initially.
How does that affect drugs?
It changes how drugs distribute.
Yeah.
Water-soluble drugs might spread differently than fat-soluble ones compared to an adult. And again, their elimination systems, liver and kidneys, are maturing. So dose adjustments are critical based on age and sometimes weight. You see it with drugs like lithium. If kidney function declines with age and the dose isn't reduced, it can build up dangerously.
Okay, so age is critical. Now, side effects. We all know drugs have them, but sometimes they seem to happen in places totally unrelated to where the drug is supposed to work. Like, why would an asthma drug affect your heart?
Yeah, that's a great question. It gets back to the complexity of the body. It's rare for a drug target like a receptor to exist only where you want the drug to act.
Ah, so the lock exists, it's elsewhere too.
Often, yes, or there are very similar locks elsewhere. So those asthma drugs, they target beta-2 receptors in the airways to open them up. But your heart has very similar beta-1 receptors.
The drug hits both.
It can, yeah. Leading to palpitations, maybe a faster heart rate. It's an off-target effect, but predictable because of receptor similarity.
And the reverse is true too.
Exactly. Beta blockers targeting beta-1 in the heart can sometimes block beta-2 in the airways, potentially causing breathing problems in people with asthma.
Okay.
Or think about chemotherapy. It targets rapidly dividing cancer cells. But other cells in your body divide rapidly too.
Like hair follicles, gut lining.
Precisely. Which is why hair loss, nausea, and vomiting are common side effects. And bone marrow suppression, reducing blood cell production, is another major one because those precursor cells divide quickly.
Right. Even antibiotics you mentioned.
Yeah, some types, like aminoglycosides, can cause kidney damage, even though their main job is killing bacteria elsewhere in the body. It just shows how interconnected everything is.
That bone marrow suppression sounds particularly serious.
It is. It's often one of the most severe adverse effects because it affects all your blood cells, red cells carrying oxygen, white cells fighting infection, platelets for clotting.
And you might not know right away.
That's the scary part. These drugs often hit the developing cells in the marrow, not the mature ones already out in your blood. So significant damage can happen before your blood counts actually drop, and you start seeing symptoms like fatigue, infections, or easy bruising and bleeding.
So monitoring is key.
Absolutely vital. Regular blood tests, checking hemoglobin, white cells, platelets are crucial during treatments known to affect bone marrow. The worst outcome is aplastic anemia, where production of basically all cell lines shuts down. That's life-threatening.
Wow. Okay, shifting slightly, thinking about daily routines. Sometimes you're told, take this pill with food. Is that just a suggestion or is there a real reason?
Oh, there's usually a very real reason. It's not always about helping absorption. Sometimes it's the opposite. But often it's about protecting your stomach. Some drugs, especially acidic ones like NSAIDs, think ibuprofen, naproxen, can really irritate the lining of your stomach or esophagus. Taking them with food acts like a buffer, reducing that irritation, maybe preventing nausea or even damage like ulcers. So yeah, if it says take with food, definitely do it.
Good advice. Okay, let's zoom in on some specific areas where drugs play a huge role. The brain, for instance. Epilepsy.
Right. Epilepsy involves recurring seizures, basically bursts of uncontrolled electrical activity in the brain. The drugs work in different ways to try and calm that down. Some increase the effect of GABA, which is like the brain's main calm down neurotransmitter. Others work by blocking specific channels in nerve cells, like sodium channels, to sort of stabilize the electrical firing. Phenytoin, carbamazepine, Valproate, those are common examples.
What are the particular challenges with those?
Well, phenytoin is a good example of tricky dosing. Its effects can really change depending on the level in the blood. Too much can cause sleepiness, double vision. And it's famous for interacting with lots of other drugs because it affects those liver enzymes we talked about.
Ah, induction and inhibition again.
Yep, it can do both, complicating things.
What about depression?
Depression is often linked, chemically, to reduced levels of neurotransmitters like noradrenaline or serotonin in certain brain pathways.
The feel-good chemicals.
Kind of, yeah. They regulate mood, among other things. So antidepressants typically work by increasing the amount of these chemicals available in the synapse, the gap between nerve cells.
How do they do that?
Usually by either blocking the nerve cell from reabsorbing them too quickly, that's what SSRIs, selective serotonin reuptake inhibitors, do, or by stopping enzymes from breaking them down. Older drugs like tricyclics did this too, but often had more side effects, which is why SSRIs are more common now.
Okay. And ADHD. Attention deficit hyperactivity disorder.
A behavioral disorder usually diagnosed in childhood or adolescence, characterized by trouble focusing, hyperactivity, impulsivity. Interestingly, it seems to affect males more often, maybe 4 times more.
Any idea why? What's going on in the brain?
The thinking involves how the brain regulates impulses and attention, particularly in the frontal lobes. There's evidence suggesting issues with the dopamine system. Maybe dopamine gets cleared away too quickly. Dopamine is key for reward, motivation, focus.
Which explains why stimulant medications are often used.
Exactly. They aim to help regulate that dopamine system, improve focus, and reduce hyperactivity.
Okay, let's talk about pain. Everyone knows pain, but you mentioned it's not always the same. Acute versus chronic.
Yeah, really important difference. Acute pain, like stubbing your toe, or after surgery, it feels like a clear danger signal. Your body reacts automatically. Heart races, blood pressure goes up, pupils might dilate. You feel anxious. It drives you to stop doing whatever's causing it.
Your body's alarm system.
Exactly. But chronic pain, like persistent back pain, arthritis, it's different. It's not signaling an immediate danger in the same way. The body usually doesn't have those strong, visible fight or flight reactions.
But it still has huge effects.
Oh, profound effects. It can lead to depression, people become inactive, isolated. It just wears you down, diminishes your quality of life, even if there aren't those obvious signs like a racing heart. Treating it requires a totally different approach than acute pain.
That makes a lot of sense.
Mm-hmm.
Okay, another major area, fighting infections. But sometimes it seems like the bugs are winning. Why are some infections so hard to treat?
Antimicrobial resistance, yeah, it's a massive global challenge.
Why does it happen?
Well, some microbes are just naturally resistant to certain drugs. That's primary resistance. But the bigger problem is acquired resistance. That happens when microbes change genetically, either picking up resistance genes from other bacteria or through random mutations allowing them to survive drugs that used to kill them.
And how do the drugs work in the first place, when they do work?
They usually target something specific to the bacteria that our cells don't have or have in a different form. Like the cell wall penicillin breaks that down, bacteria burst, or they target bacterial protein-making machinery, aminoglycosides do that, or they interfere with how bacteria copy their DNA.
Any examples where things get complicated?
Sure. Chloramphenicol, an antibiotic, stops bacteria making proteins. But at really high doses, it can actually start interfering with our mitochondria, the energy factories in our own cells.
Whoa.
Yeah. Or macrolides, like erythromycin. They get broken down by that same big liver enzyme system, cytochrome P450, that handles lots of other drugs.
There's some interactions again.
Big time. If someone's on warfarin, taking erythromycin can slow down warfarin breakdown, increase bleeding risk. You have to be really careful.
Okay, finally, let's touch on drugs of abuse. People understand the risks. What are the general dangers?
Well, broadly, narcotics and other substances prone to misuse cause a whole range of harms, physical, mental, social. People who use them chronically often have more anxiety, confusion, panic attacks, and they're just way more exposed to injuries, accidents, infections, other diseases.
What about specific examples? Cannabis.
The main active bit in cannabis is THC. It's psychoactive. Importantly, it doesn't dissolve in water. That makes injecting it incredibly dangerous. You risk particles blocking blood vessels, plus massive infection risk from contamination.
Okay. And stimulants. Cocaine, amphetamines.
Those work mainly by boosting levels of certain brain chemicals, noradrenaline, serotonin, dopamine in the gaps between nerve cells. They either block reuptake or force more release.
What do those chemicals do?
Noradrenaline jacks up heart rate, blood pressure. Dopamine is heavily involved in the euphoria, the buzz, the hyperactivity people feel.
And benzodiazepines, like Valium.
Benzos enhance the effect of GABA, that calming neurotransmitter. So they reduce anxiety, sedate, relax muscles, can stop spasms.
But they have dangers, too.
Definitely. Injecting them carries those same risks of contamination and particles. But the really critical danger is mixing them with alcohol or other things that depress the central nervous system, like opioids.
Why is that so bad?
They have a synergistic effect, meaning 1 + 1 doesn't equal 2. It equals maybe 5 or 10 in terms of slowing down your breathing. It can easily become fatal. Combining CNS depressants is incredibly risky.
A really stark warning there. Okay, on a completely different but equally urgent note, poisoning. When it happens, it's a race against time, isn't it? What are the immediate priorities?
Absolutely a race. The main ways people die from poisoning are usually respiratory failure. They stop breathing, or heart problems like arrhythmias or cardiac arrest.
So step 1.
Get information. Fast. What was taken? When? How much? Knowing the circumstances is crucial for choosing the right treatment quickly. Then, the absolute basics. Maintain vital functions. Keep them breathing ABCs, airway, breathing, circulation. Stop any seizures. And try to prevent any more poison being absorbed.
And beyond those first steps, more advanced things.
Yeah, depending on the poison. Sometimes hemodialysis can be used, basically filtering the blood to remove certain substances if they're small enough molecules. Things like theophylline, phenytoin.
Like an artificial kidney?
Kind of, yeah. Peritoneal dialysis is another option, uses the lining of the abdomen, but it's usually less effective than hemodialysis.
Are there specific antidotes?
Sometimes. For methanol poisoning, like from bad moonshine, you might need dialysis. But also ethanol or a drug called fomepizole can help. Aspirin overdose needs rapid treatment to correct acid levels in the blood, plus potassium and maybe diazepam if there are seizures. Iron poisoning, which sadly happens sometimes with kids getting into supplements, is really dangerous because iron is corrosive. It burns internal tissues. Needs specific treatment quickly.
Wow. Okay, so we've covered a massive amount of ground here.
We really have.
So thinking about all this,
Yeah.
what does it mean for you, the listener, the learner? We've gone from, ethical drug development, natural origins, right, through how your body handles these chemicals, the dynamics and kinetics. Looked at specific conditions like epilepsy, pain, talked interactions, age factors, even emergency poisoning treatment. It's incredibly complex, isn't it?
It truly is.
But hopefully, understanding these basics empowers you, makes you a more informed person when you're navigating health information, talking to your doctor, understanding your own medications.
Absolutely. And if we connect all this back to that bigger picture, knowing just how vastly different our individual responses to drugs can be because of age, genes, other meds, everything we've talked about, it really raises a fascinating question, doesn't it?
Which is?
In this era where we're talking more and more about personalized medicine, how far can we actually push that? How much further can we refine our understanding to tailor treatments precisely to you? Imagine minimizing errors, maximizing benefits, because the treatment is designed truly for the individual.
Bespoke medicine.
Exactly. Designed for one person. Think about the implications of that. That's really the frontier we're aiming for. Something to mull over.